Welcome to Grand Rounds at Walter Reed Army Medical Center. Today it's my privilege to introduce Lieutenant Colonel David Vaughn, who is the Chief of Virology at Walter Reed Army Institute of Research. Dr. Vaughn graduated from St. Louis University and did an MPH at Johns Hopkins University. He's a pediatric virologist and actually was the Chief of Pediatrics at Nuremberg, Germany for 4 years, and then went to viral diseases at Rare and spent 6 years as the Chief of Virology at the Armed Forces Research Institute for Medical Sciences in Thailand, where he did extensive work in dengue. He's now the Chief of Virology at Rare. He's published over 180 articles and abstracts on dengue, hepatitis E, and Japanese B encephalitis. He's a consultant to the World Health Organization in dengue, and today he's going to be discussing dengue fever and dengue hemorrhagic fever, two diseases of great military importance. Dr. Vaughn.
All right, thank you very much for the introduction, and good afternoon. We'll go right to the slides. Those show up. I've put my email address here on this first slide and also on the last slide of my talk. So if there's anyone that'd like to contact me to talk about dengue further, or anyone who's interested in an assignment in the Department of Virus Diseases at Rare or at one of our overseas laboratories, please contact me. This afternoon, I'm going to give a brief overview of dengue fever and dengue hemorrhagic fever. You do, on rare occasions, see dengue fever in this hospital and at the Naval Hospital in Bethesda. And we have plans to bring more dengue patients to you. We are setting up a protocol to reintroduce a dengue challenge model where we will give near wild-type viruses to volunteers who have been vaccinated with our candidate vaccines. In January of this year, Major Mammon, who is here today, will start this process. He will inject as many as 10 or more volunteers with near wild-type dengue virus, and we fully expect that they will develop dengue fever. And when they do, they'll be admitted to this hospital, Ward 75. So we thought it'd be a good idea to give a little bit of an introduction to dengue and dengue hemorrhagic fever. Up until August, the Department of Virus Diseases was located here at the old building about 200 meters from here. And you can't read it, but the south wing is named after a gentleman named Craig, and I'll tell you a little bit more about him a little bit later. Since August, we've moved to join our Navy colleagues at the new Rare in Maryland. But my experience with dengue comes from the 6 years I spent at the Armed Forces Research Institute of Medical Sciences, better known as AFRIMS, in Bangkok, Thailand. Here's the lecture outline. I'll give you just a little bit of the background and how the Army got into the dengue business. A little bit about the epidemiology. We'll spend most of our time on dengue disease. Just a little bit about pathogenesis, diagnosis, treatment, and I'll tell you the status of dengue vaccine development. The first good clinical description of dengue fever actually comes from the United States. There was an outbreak of dengue fever in Philadelphia in 1780, over 200 years ago. And Dr. Benjamin Rash reported his experience in treating these patients. Dr. Rash was a signer of the Declaration of Independence and the namesake for Rush Medical College. It's actually quite a delightful article to read. I've kind of translated it a little bit more to English and have it as a WordPerfect file if anyone would like to read it in its entirety. The Army's interest in dengue began with the Spanish-American War. In February of 1898, the battleship Maine was stationed in Havana Harbor in a show of support for Cuban nationalists seeking independence from Spain. On the evening of February 15th, the Maine exploded. Extremists in the United States thought that the Spanish were somehow responsible. After unsuccessful negotiations that lasted about 4 months, war was declared between the two countries in April of 1898. The war was fought in the Spanish colonies of the Philippine Islands, Cuba, and Puerto Rico. After battles with minimal U.S. casualties, ceasefire was officially declared in August, and a peace treaty was signed in Paris in December of 1898. After what the Secretary of State John Hay called a splendid little war, the U.S. took possession of Cuba, Puerto Rico, Guam, the Philippines, and as a direct result of the war, also annexed Hawaii, Wake Island, and several of the Samoan Islands. Dengue was a considerable problem for U.S. forces both in Cuba and in the Philippines. As a result, a dengue commission was established in 1900, and researchers were sent to the Philippines to study this problem. Here's Dr. Craig, who I mentioned before, and Dr. Ashburn, who I just noticed a few minutes ago was the 4th commander of this hospital as a major. They demonstrated that the causative agent of dengue was ultramicroscopic and non-filtrable, in their words, or a virus in our words. What they did was they took whole blood from dengue patients and administered that to healthy volunteers who developed dengue. Then they took blood, removed the cells, gave the serum to volunteers, they developed dengue, and finally they took the serum and passed it through small pored filters that they knew would remove any bacteria or parasites, and gave it to volunteers who also developed dengue. They confirmed that it was transmitted by mosquito. They made good, careful clinical descriptions, and they showed that they could only infect a volunteer once. That infection induced absolute immunity, which of course has important implications for vaccine development. Epidemiology. This map shows the distribution of dengue fever and dengue hemorrhagic fever. It's out of date. The yellow representing outbreaks of dengue fever and the red dengue hemorrhagic fever. There should be a great deal more red in our hemisphere on this map. There are about 2.5 billion people at risk for dengue. They're at risk because they live where the primary vector mosquito, Aedes aegypti, is located, and because it's warm enough for the virus to grow on the mosquito for at least portions of the year. There are an estimated 100 million infections each year due to dengue virus, and possibly just as many clinical cases as well. The morbidity can be significant, even with dengue fever lasting as long as 3 weeks. As a military problem, we've already talked about the Spanish-American War. In World War II, there were 90,000 reported cases of dengue fever. However, there were no diagnostics, and dengue fever can look like other fevers, so this is probably a gross underestimation of the true disease burden. There were outbreaks where as much as 80% of a unit was affected by dengue. And on Saipan, there was an outbreak of 20,000 cases in just 3 months. During the Vietnam War, dengue was a frequent cause of fever. Australian untacked tubes in Cambodia, it was their biggest problem. In Somalia, about 1/4 of the fever admissions were due to dengue. And in Haiti, 30 of the 105 fever admissions were due to dengue. It was the most common cause of admission due to fever. The ecology is pretty straightforward. Mosquitoes transmit the virus from person to person. If there are any entomologists in the audience, I apologize. This is not an Aedes aegypti mosquito, but it was the best mosquito picture that I had. My second best picture is here. This is a Gary Larson cartoon, Far Side, and it says, "What a day, I must have spread dengue across half the country." Now, the problem with this cartoon is that it has a stereotypic male coming home from work at the end of a long day. But actually, only the female mosquitoes can take a blood meal and transmit dengue. The spectrum of dengue disease. As I mentioned, the first good clinical description of dengue was in 1780. There's some very good paragraphs in there talking about the acute phase of the illness. including fever, headache, and myalgias, malaise, which is universal. Joint pain is very common, anorexia, nausea, and so on. There's a long list here. I won't read them all. But most of the other symptoms are fairly non-distinct. The convalescence from dengue can be prolonged. It can last for several weeks. There's an asthenia that's experienced. In the Benjamin Rush paper 200 years ago, he describes 2 women that complained about their weakness and tiredness. And these women suggested that the disease then was known as breakbone fever. They suggested that the convalescence should be known as break heart fever. Dengue hemorrhagic fever, the main difference between dengue fever and dengue hemorrhagic fever is the occurrence of plasma leakage, which starts generally around the time of defervescence. Dengue hemorrhagic fever was widely recognized in the 1950s following large outbreaks in the Philippines and Thailand. At the time, the disease had an untreated mortality of around 10 to 20%. It was quickly learned that the optimal treatment was good fluid management. DHF affects all ages, but is much, much more common in children in endemic areas. And again, the key pathologic processes are plasma leakage and hemorrhage that distinguish it from dengue fever. This is the World Health Organization grading scale for dengue hemorrhagic fever. They distinguish between, okay, we'll go the rest of the way with, oh, there we go. They distinguish between dengue fever and dengue hemorrhagic fever. And again, the most important difference is plasma leakage. If there's enough plasma leakage, then the patient will experience shock or dengue shock syndrome, dengue hemorrhagic fever grade 3 or grade 4. An interesting thing about dengue hemorrhagic fever, when there's shock, the systolic blood pressure does come down, but more importantly, the diastolic blood pressure comes up, and the pulse pressure narrows. And at some point, it narrows to the point where you cannot detect a pulse nor measure a blood pressure, and that is called DHF grade 4. Now, if there is plasma leakage but not enough to cause shock, then it's dengue hemorrhagic fever grade 1 or grade 2. You need to identify plasma leakage. This is usually done by showing that there's a pleural effusion, ascites, or most commonly, hemoconcentration. As the plasma leaves the vasculature, the blood cells are concentrated, the hematocrit goes up. And if it goes up by 20% or more compared to baseline values, that's good enough for a diagnosis of dengue hemorrhagic fever. Now you'll notice that I haven't even mentioned bleeding until this point. The most important factor is the plasma leakage. However, you do need a component of hemorrhage, which can be merely a bleeding diathesis. In DHF grade 1, there's a low platelet count, 100,000 or less, and a positive tourniquet test. And I'll describe that test in a moment. In grade 2, there's spontaneous hemorrhage, most commonly petechiae, epistaxis, or GI bleeding. An example of plasma leakage, pleural effusion. In our research, we measure the depth of the pleural effusion in a right lateral decubitus chest x-ray divided by the diameter of the right hemithorax times 100. And here's some data. For dengue fever patients, there's little or no pleural effusion, almost by definition, really. Grade 1 to grade 2, in our study, we had an average of about 15% of the right hemothorax filled with fluid. And in the shock cases, closer to 40%. And we saw up over 80% of the right hemithorax filled with fluid. This peaks about 24 hours after defervescence. During the febrile phase, dengue fever and dengue hemorrhagic fever really look the same. Headache, muscle ache, eye pain, so on. But at the time of defervescence, if there's going to be plasma leakage, that's when it occurs. Another example of plasma leakage, ascites. I have a distended abdomen here. In our research, dengue fever, very little, but by the time you get to the shock cases, essentially 100% of patients have easily identifiable ascites. This also peaks about 24 hours after defervescence and can be made much worse with over-aggressive fluid administration. And the combination of ascites and pleural effusion can lead to respiratory embarrassment, as seen in this patient. Another clinical finding, hepatomegaly, unusual in dengue fever, but reasonably common in dengue hemorrhagic fever. There is an elevation of liver enzymes associated with dengue virus infection. In our studies, dengue fever with a modest increase on average, and more so in dengue hemorrhagic fever. There can be a fulminant hepatitis that occurs with dengue fever, although this is a fairly rare event. Something that's a little bit unusual is that in dengue fever, the AST is higher than the ALT. And it's usually the other way around for classic hepatitis, hepatitis A or hepatitis B. I mentioned the Tourniquet test earlier. This is performed by applying a sigma-manometer, inflating it to midway between the diastolic and the systolic blood pressure, leave it there for 5 minutes, release the pressure, and let the vascular congestion clear for about 2 minutes, and then count the number of petechiae in a 2.5 square centimeter area. If there's more than 10 petechiae, then this is considered positive. Perhaps some of you will be doing this test in January. It's been used to help with the diagnosis of dengue. You can see here that in dengue fever and dengue hemorrhagic fever, it's almost always positive. But the problem is that in our research, in Thailand at least, 60% of the children with a non-dengue presumed viral infection also had a positive test. So the positive predictive value is fairly low for this test. But it does give you an idea of capillary fragility. The classic rash of dengue, there's actually 3 rashes that have been associated with dengue fever, and they're seen in about half of the patients. Early on, with the onset of fever, there's a classic flushing or blushing, redness of the face, neck, and chest. We see this fairly commonly in our vaccine recipients, actually. And this can last a day or two. Following that, there's a slightly different rash, an erythematous macular or macular-papular rash that begins on the trunk and spreads to the face and extremities. And there can be little islands of normal skin among this erythematous rash. And finally, maybe around 7 days or 8 days into the illness following defervescence, there's the most classic rash of dengue, which is a petechial rash, generally of the lower extremities, but also seen in the buccal mucosa and palate. So this patient has the early rash, also with a conjunctival suffusion, which is commonly seen. All right, bleeding. Bleeding can occur in dengue fever, and a reference I looked at recently, it said 5 to 30%. That may be just a little bit high. Certainly high for significant bleeding. But this may manifest as petechiae, purpura, epistaxis, gingival bleeding, or menorrhagia. Bleeding is more common, in dengue fever there can be significant bleeding, and there was a report out of Taiwan where there was serious GI hemorrhage from 15 male patients with dengue fever. All of them had a pre-existing gastric ulcers. And so when they had the dengue fever, it exacerbated that remarkably. Significant bleeding requiring transfusion occurs in about 10 to 15% of the patients at the Bangkok Children's Hospital with DHF. Most common is GI bleeding, and this is a frequent cause of death following prolonged shock and metabolic acidosis. The GI bleeding can be occult for many hours, and you need to be suspicious for that. Clinical laboratory thrombocytopenia, prolonged prothrombin time and partial thromboplastin time, as well as low fibrinogen levels. Just 2 slides on dengue pathogenesis. Actually, this is what I spend most of my time talking about, but we won't emphasize it today. This is a figure that was published by Dr. Ichiro Kurani at the University of Massachusetts, and he based this figure on a publication by Don Burke while Dr. Burke was working at the Aframs laboratory, and it's sometimes called the Burke pyramids. Dr. Burke did a prospective study of school-age children, and what he found is that for every child who came to the attention of healthcare providers who were hospitalized, there were another 9 or 10 who were infected but who had subclinical infections. The second observation was that children who were having a second or third dengue virus infection were much more likely to be hospitalized than children that were having their first. I think I failed to mention that there are actually 4 dengue virus serotypes, cleverly named dengue virus type 1, type 2, type 3, and type 4. And with the first infection, there's a risk of severe disease, but with subsequent infections, that risk increases. This was explained by Dr. Scott Halstead in the 1970s. He was actually the first chief of virology at the Aframs laboratory. His theory was that heterotypic cross-reacting neutralizing antibody allows more dengue virus to get into more cells to worsen the infection. Let's say you're infected with a dengue virus type 1. You get sick, you generate neutralizing antibody, you clear the virus, and in theory you're protected from dengue 1 virus for the rest of your life. Say 3 years later you're infected with dengue 2 virus. That dengue 1 virus will bind to the dengue 2 virus but not neutralize it. And the Fc receptor of that immunoglobulin actually helps the virus to get into Fc receptor-bearing cells, such as monocytes and macrophages, and perhaps most importantly, dendritic cells. More virus into more cells, more replication, increased viral load, an increased response to the presence of that virus, and more severe disease. On pathogenesis, there are many, many other factors to be considered, but we'll leave those for another time. Diagnosis, laboratory diagnosis. Using the WHO criteria, a diagnosis of dengue hemorrhagic fever can be made on a clinical basis. And in fact, at the Bangkok Children's Hospital, 95% of the children that they say have dengue hemorrhagic fever are confirmed in the laboratory. And most of the other 5% have indeterminate serology. This is data from the Dengue Hemorrhagic Fever project. This represents 66 children who are having a primary or first dengue virus infection. The first line I want you to look at is this blue or cyan. This represents the mean maximum temperature for these 66 children. In dengue fever, the temperature profile is a fixed high temperature and then a sudden defervescence. The x-axis here has fever day. Fever day 0 is the day of defervescence, and the negative numbers are days before defervescence and positive numbers day after. This magenta line represents viremia, and you can see that it correlates very closely with fever. And the message here is that if a dengue patient has fever, they're viremic, and as the fever goes away, the virus goes away. The second message is that when they're viremic and febrile, there's not enough antibody for a diagnosis. In the convalescent period or after the fever goes away is when you make the diagnosis by serology. And in a primary infection, the IgM level is at least twice as high as the IgG. In a secondary infection, it's reversed. The IgG level is much higher than the IgM. This is data from 246 children with secondary infections. The fever curve and the viremia curve are similar. They're not the same, but they're fairly close. So how do we diagnose dengue at the Aframs laboratory and here at Rare? Well, if they're during the febrile phase, we try and isolate the virus. At Aframs, we do it by injecting the serum into live toxorhine kinase mosquitoes. That's what's being shown here. It's tedious work, as you might imagine, and that's being replaced by PCR. At Rare, we use mosquito cells, in cell culture instead of live mosquitoes, but we also use the PCR method. In terms of a serologic diagnosis, we use ELISA, hemagglutinin inhibition assay, and plaque reduction neutralization assay. In the last few years, there have been several commercial assays that have come out on the market, and several of these are quite good. Treatment. For dengue fever, there really is no treatment. It's not required generally. It's a self-limited illness. During those rare cases where there's significant hemorrhage, blood products may need to be administered. Acetaminophen can be given for comfort. Aspirin is contraindicated due to its effect on platelet function and the risk of Reye's syndrome. Oral hydration is generally all that's needed. In addition, what's most important is careful monitoring either at home or in the hospital. And if dengue hemorrhagic fever develops, then they need to be admitted and cared for. As I mentioned before, dengue fever and dengue hemorrhagic fever look the same until the time of defervescence. For the treatment of dengue hemorrhagic fever, here are just a few pointers. First, prognosis depends on the early recognition of plasma leakage. The children that die at the Bangkok Children's Hospital are generally those that get to the hospital late. They've been in shock for some time. There's end organ failure, and it's just too late to revive them. But with good, careful fluid management, that should be very rare. Again, leakage starts after the third day of illness, around the time of defervescence, which on average in Thailand is about the fifth day of fever. This plasma leakage is very short-lived. It lasts only 24 to 48 hours. Dengue hemorrhagic fever is very interesting. The plasma leakage starts very quickly and ends just as quickly. So you must be careful with the fluid management. After the plasma leakage ends, you need to back off on the fluids, or you can lead to excessive pleural effusion, ascites, and pulmonary congestion. This was noted in Thailand in the late 1950s and early 1960s. They had this high mortality rate, 10 to 20%. They started giving fluids aggressively. The mortality rate dropped dramatically. But then it started to go back up again, and those deaths were probably due to iatrogenic fluid administration. And so they learned to balance the fluid administration. Now, I provided this algorithm as a handout at the back of the room. This was put together by Dr. Sharon Green at the University of Massachusetts and myself for the current version of Hunter's textbook of tropical medicine. It actually takes the work of Dr. Suchitra Nimanit of the Bangkok Children's Hospital. She had about 3 or 4 pages of algorithms, and we tried to simplify it into a single page. And I won't go through it, but I'll let you look at it. Basically, you enter it here, decide whether a patient may or have dengue or not. Are they in shock? Yes. Bolus with fluids. Are they better? No. Give more fluids. Are they better? No. Well, maybe you've given too much fluid, or they're bleeding. You need to give blood, and so on. Finally, dengue vaccine development. But before we talk about the specific vaccines that we're working on, I must point out that there is no dengue vaccine. And so the only way to prevent dengue is to avoid the mosquito vector. The most important vector is the Aedes aegypti mosquito. And a second important vector is Aedes albopictus. Aedes aegypti can be found across the coastal regions of Texas through Florida, and even comes as far north as Washington, D.C. on occasion. The Aedes albopictus is found from the Midwest and throughout the East Coast. I told you about outbreaks in Philadelphia, and there have been many dengue outbreaks in the United States over the years, but those really kind of went away in the 1940s. The Aedes aegypti is sometimes called the stealth mosquito. It's a day biter, but it bites you in the back of your ankle, the back of your elbows. You don't even know that you've been bitten. Australian entomologists told me that they like to bite around 9 o'clock in the morning and 4 o'clock in the afternoon, and they've sometimes been referred to as the tea time mosquitoes. So personal protection is clothing. Tuck the pants into your shoes or boots. 30% DEET on exposed areas. Vector control is of limited effectiveness. You can reduce the number of adult mosquitoes by aerial spraying, but only for a couple days. Reducing the number of breeding sites is effective to a degree. These mosquitoes like to breed in small collections of water, abandoned tires, cups from McDonald's, and so on, which are now found worldwide. These are the dengue vaccine candidates. This table was put together by my predecessor, Dr. Bruce Innes, and he's listed the 7 that are furthest along. The ones highlighted in yellow are the ones where Rare has produced a vaccine like this or is otherwise heavily involved in the development. And we'll go through these. The first 2 are live attenuated virus vaccines. The Walter Reed Army Institute of Research has developed vaccines for each of the 4 dengue types and has put them together into a tetravalent formulation. Dr. Wellington's son in our department leads this effort. The Mahidol University in Bangkok, Thailand has developed a similar vaccine, and that has been licensed to Pasteur Mario Canat. Both of these vaccines were produced by taking dengue viruses and passing them over and over again in primary dog kidney cells, as many as 50 times, to weaken and attenuate the virus. These vaccines are in phase 1, phase 2 human trials at the present moment, and show good promise to be effective vaccines. Other live approaches are the next set here, Chimera. The National Institute of Allergy and Infectious Diseases at the NIH has produced a full-length clone of the dengue 4 virus. They then deleted parts of the 3' end of the genome, and they feel that this has attenuated the virus for use in humans. And in fact, they plan a phase 1 trial at Johns Hopkins University in December. And Rare will be providing clinical consultation and entomologic support for that. The CDC, working with Mahidol University, have taken a full-length molecular clone of the dengue 2 vaccine virus and hope to use that as a vaccine. Now, for both the dengue 4 and the dengue 2 clones, if they work as vaccines, then what they'll do is to replace 2 of the genes that code for structural proteins with genes from the other viruses. So they'll replace the membrane protein and the envelope protein with the genes from, in this case, dengue 1, 2, and 3, in this case, dengue 1, 3, and 4. Oravax is taking a slightly different approach. They've started with the full-length clone of the yellow fever vaccine virus, one of the most successful vaccines in history. It's cheap, it's safe, you give 1 dose, you have lifelong protection. And so they want to build on that success by replacing the structural genes with dengue genes. They have actually constructed a yellow fever Japanese encephalitis chimera, and Dr. Naranjan Kanesatasan in our department plans to put that into people in April or May of next year, and to follow that very closely with phase 1 trials of the dengue vaccine. Now I'm going to back up here and explain this column, number of genes. Dr. Innes felt that the number of genes we give to vaccinees is important, and that the more, the better, the broader the immune response will be. With a live attenuated virus, you're giving all 10 genes, and in fact, if it's a tetravalent vaccine, you're giving 40 genes worth. With the chimera, you're giving 2 specific genes, and then closely related genes. We're now down to inactivated vaccines where there are 4 genes. This work has been led by Dr. Bob Putnack and Dr. Ken Eccles at Rare. They took dengue virus, grew it to high titer in cell culture, and then inactivated it. A very classic method for making a vaccine. So they have the 3 structural proteins in there, the capsid, the membrane, and the envelope. And fortuitously, one of the non-structural proteins, NS1, also came out with the vaccine. Even smaller are recombinant subunit vaccines that use only the envelope protein or only a portion of it. Hawaii Biotechnology Group has made such a vaccine, so has Institut Pasteur. Dr. Eileen Kelly in our laboratory has produced such a vaccine, and the Navy group at NAMRIC have also made a vaccine like this. I would say that the Hawaii Biotechnology Group is furthest along. They've demonstrated good protection in a monkey model. And finally, among the promising approaches to dengue vaccines is the naked DNA approach. The Navy is kind of the lead agent in our institute for developing this. They're working with a company called Vical. The Army side of the house has their own DNA vaccine, and we're working with a company called PowderJect. These vaccines have been shown to protect monkeys from challenge with wild-type virus. The concerns with the DNA approach is that multiple doses are required over several months, and steps are being taken to try and reduce the number of doses and the amount of time required to administer the vaccine. So we've just gone over many, many different approaches to vaccine. How do we choose among them? Well, first is that we demonstrate their ability to protect monkeys from a live virus challenge. Dengue viruses do not make monkeys sick, but they do experience a viremia that we can measure, generally about 5 days of viremia. And so these vaccines are able to reduce that or eliminate that viremia. Another important factor is commercial feasibility. We may develop the perfect vaccine, but if it's $200 a dose, we may have a problem finding a manufacturer to make and sell the vaccine, since the profit margin will be so small. Another cut point is showing safety and immunogenicity in humans. And our goal there is to mimic natural immunity to the extent possible, both in terms of antibody response and T-cell responses. And finally, what we'll start here in January is we're reestablishing a challenge model. It's been used before, but not since the 1940s, and Major Mammon is organizing this. The aim of the study in January is to expose unvaccinated volunteers to near wild-type dengue viruses to show that we can consistently and reproducibly cause dengue disease in these volunteers. Later, future studies, we will give these challenge viruses to volunteers who have received a candidate vaccine to see if they are indeed protected from the challenge. We anticipate that this will greatly accelerate our vaccine development. Currently, the only other way to show protective efficacy for the vaccine is to give the vaccine to tens of thousands of school children in endemic areas, along with a control vaccine to additional tens of thousands of children, and to see who develops disease. Very expensive, very time-consuming. Now, those of you that have been involved in human research know that there's a considerable approval process, and this is where this protocol is at the moment. It's been approved by the Rare Scientific Review Committee. It's been approved by the Rare Human Use Review Committee twice. It's been approved by the Rare Clinical Investigations Committee, by the Ramsey Human Use Committee, and it's been considered by the Human Subjects Research Review Board in the Office of the Surgeon General. They had questions about the risk of transmitting these viruses from the volunteers to the community, and they have requested additional documentation to show that this is a highly unlikely event, and Dr. Mammon is supplying that. So, in conclusion, we've talked about dengue fever, a self-limited illness. It's not pleasant. The joke about dengue fever is that it won't kill you, but you wish it would. Dengue fever is less common, but can be fatal. It's very rare in adults, and it's very rare in persons who have not been primed with an earlier dengue or other flavivirus infection. I've told you about several dengue vaccine candidates. It'll be at least 5 years before one of these can be licensed in the United States. And we've discussed the challenge model that should accelerate dengue vaccine development and is scheduled to start in January. And again, I have my email address down here. and I'd be happy to take questions. Thank you.
One of the clinical findings was bradycardia with in the presence of a high fever. Are there other infections that are endemic in those areas that might look like that as well?
Not that I'm aware of. There could be. That's fairly distinctive for dengue fever and dengue hemorrhagic fever. Yes?
Do you have any serologic way of detecting prior infection?
Yes, we do have serologic methods to detect previous infections. One way is by the titer of the antibody response to the current infection. If it's very high anamnestic in appearance, then we presume that they've had a flavivirus infection in the past. Using our routine ELISA, if the IgM antibody response is high compared to the IgG, we consider that diagnostic for a primary or first dengue virus infection. If the IgG level is much higher compared to the IgM, then we consider that evidence for a secondary infection. It's also possible if you get a specimen very early in the infection that you can see pre-existing neutralizing antibodies that suggest that there's been an infection in the past.
Any way to tell in an acute case, though? Do we have any way available to us about?
No. You have to wait until the time of defervescence or a few days after that to look at the antibody profile. We have some recent data that shows that the virus titer is much higher in children who are experiencing a secondary infection than those who are experiencing a primary infection. But it generally takes us weeks to titer out the virus using our current technology. We're working on new technology so that can be done in a day or two, but it's not a practical method to decide whether a person is having a primary or secondary infection during the febrile period. Yes.
Can you explain how that pulse pressure narrows, how that works pathophysiologically?
No. I don't know. We have other dengue experts that are here. Dr. Sun, Dr. Knessettassin, Dr. Mammon, can you answer that question for me about the pathophysiology behind the narrowing of the pulse pressure? I assume that there's just increased vascular constriction that allows that to happen.
You mentioned the problem with fluid replacement in people who are hypotensive. How do you recommend monitoring that?
Good question. How do we monitor fluid administration in people with hypotension? Well, you give fluids until they're no longer hypotensive. The other things to monitor are the heart rate, and what's most specific for dengue is the hematocrit. Children who come in with significant plasma leakage have a high hematocrit. The normal in Thailand is probably about 35%. They'll come in with a hematocrit of 40, 45, 50, and you know that's high. And so you give fluids until you bring it down to a hematocrit of about 40, and then you monitor it. They'll do hematocrits every 2 hours routinely, and sometimes every 30 minutes. And if the hematocrit is going up, they give more fluids. And if the hematocrit is going down, they'll back off a little bit, and they'll think about the possibility of hemorrhage as another explanation for the drop in hematocrit. Okay. Okay. Any other questions? All right, thank you.